Добрый день.
Good afternoon, dear colleagues. We start our session, which is dedicated to utmost interesting and important theme, development of medical decision-making support system. Before we start, please let me introduce the participants of this session. This is Martin Gilbert. Before 2014, he was head of Kaiser Permanente company. Robin Mann, director on digital healthcare, Boston Consulting Group company. Mr. Lee Ho-yeon, director on arrangement of digital profile of Bundan Hospital, Seoul National University, South Korea. Yulia Urozhaeva, first deputy chief of management on issues of social development. Vitaly Melinovsky, Director General of Federal Hospital Central of Expertise and Quality Control of Medical Application of Ministry of Healthcare of Russia. Alexander Gusiev, member of Expert Council of Ministry of Healthcare of the Russian Federation, the usage of information technologies and healthcare, as well as Mr. Hans Iles Wishman, who is head of Artificial Intelligence Department on Precise Diagnosis, Chief Technological Department, Royal Philips Company. So, the theme of medical decision-making support system was important all the time when we had medicine, and if 100 years ago the most urgent and the most adequate system of medical decision-making support was a medical book, a reference book of a doctor, then today, with the development of information technologies, the medical decision-making support system has totally different view. Some people, some specialists, managers in healthcare treat these systems as kind of a miracle which can solve almost all the issues of managing decision-making process in modern healthcare. Some of them are quite skeptical, and somebody is just watching or observing it. So today, I think we can discuss, we can know expert point of view at where the system of medical decision-making support is located, what input they bring into healthcare, and what are the forecasts for development. But before we start our discussion, I would like to once again, relying on new tendencies, to arrange some interactive voting. I know that many of you have controls for voting. That is why please take your controls into your hands and vote for some issues. Number one, let us answer a question. How do you treat digitalization in medicine? Digitalization simplifies life as well as in other spheres. Modern medicine is possible only in digit. Computers will soon substitute for doctors. Or, number four, computer has a limited application in medicine. Please participate in this poll, and please let's try to understand how the audience treats digitalization. So, the voting is going on. The voting is going on. Let us stop voting. And so we see the vision of how we treat digitalization in medicine. We see that digitalization simplifies life as well as in other spheres. More than 70% supports this statement, and around 30% believe that modern medicine is only possible in digit. Those who believe that computers will are limited in medicine, well, I think that they do not use gadgets properly, and they didn't participate in voting, actually. Yuri, it's quite interesting. Who are among our audience? Maybe doctors think like that, or maybe vice versa. Somebody says, could you please raise your hands? Who are doctors among the audience? And who are not doctors? Please raise your hands who are not doctors. So, doctors dominate here. This is a very nice selection. So, let's continue our digital voting. We have 3 questions for the sessions that we would like to consider. Does a doctor need digital assistant to take medical solutions? Number 1, yes. Number 2, only young doctors need this. 3, it's important as a second opinion. 4, no need. Qualified doctors knows everything himself. Please vote. Well, we see the tendency that digital-oriented part of the audience is prevailing here, and practically most of the answers make 1/3 yes. And yes, we need it as a second opinion. We stop the voting here, and let's move on to the 3rd question. Well, the question is not directly related to medicine, but it has some hint. What kind of drivers will not know where to go if we disconnect a Yandex Navigator in Moscow? 90%, 60%, 30%, or 10%? Well, in this question, there is a huge trick, and it consists in the fact that large-scale implementation of automatized systems of medical decision-making support system can substitute for basic competences of a doctor. Number 1, the doctor of primary part. We are not speaking about therapeutical specialties, and such fears actually exist, and they are connected to examples in some other industries of economy and household, in particularly related to driving. And almost 60% of the audience believe that if we disconnect a Yandex Navigator, the drivers will not know where to go. And if the systems of medical decision-making support are disconnected, will it mean that well, what it is going to mean, we are going to discuss through our talk. So, let's get back to our speakers. And I would like to ask to share experience about efficiency of implementation and positive changes in operation of a doctor, which happened after implementation of medical decision-making support system. Mr. Martin Gilbert, please share your experience from 1983 to 2014. He was head of Kaiser Permanente company.
I think that I will start by talking about what it takes to get the doctors to buy in, because at the end of the day, at the end of the day, clinical decision support will only work when doctors want to use it. If it isn't in their better interests and it isn't making their life easier, better, they will find ways to work around it. So in the organization that I spent most of my career at, we moved to electronic health records and clinical decision support very early. But the key was that our doctors were engaged from the beginning. And the first questions that were asked is, what will make your life, what is difficult? What is difficult is finding data in a chart. What is difficult is, going to the top to see what the primary diagnosis of the patient is. And do they have any care gaps? Are they due for any immunizations? Are they due for any screening? Are there any early warning signs, etc.? So one of the key buy-ins for doctors was to make their visit, take away a lot of the questions, take away much of the going into the medical record so they could prioritize the visit and focus on the real needs of the patient. So the first part was really making life easier for the doctors. And then the second part was being very clear about, because I think the biggest thing doctors were worried about was being overloaded with prompts and reminders. Every time they would make a step in the electronic record, someone would say, "Did you do this? Did you forget that?" etc. So there was a decision that the clinical decision support would support what are the main health objectives that you're trying to improve. So an example here in Moscow, there's a huge effort at trying to pick up cancer early and make people's lives with cancer better, and also around cardiovascular disease. So in our analogy, lots of the clinical decision support would be created to really help doctors and also their staff to identify which patients were at risk for cardiovascular disease and or oncology, and how they were doing in their journey in trying to care for that. So very much success factor was around focusing clinical decision support. And I think the other piece was doctors are afraid of making mistakes and don't like rework. So if a doctor prescribed a medication that would have a bad interaction with a medication that they were already on, they loved the alert, beware, beware, things like that, because they didn't want to create those kinds of mistakes or have to call the patient back. But I think the important piece is engaging doctors along the way, paying attention to, is the visit going faster or slower with with decision support, and are outcomes actually improving, and continually trying to prioritize where you're going to put prompts, reminders, support, so that your efforts, which are actually making the doctor's day more precise, simpler, more focused, and the patient's outcome, which is a healthier life, as your main focus. And if your clinical decision support, the learning at Kaiser, was really focused on improving the lives of the patient and actually demonstrating that actually was improving because of that decision support, and that the doctors felt that the support added value, didn't take away from their own thinking, actually supported their thought processes, etc. Those were the key learnings.
Спасибо. Спасибо.
Thank you very much. Well, now a similar question I would like to address to Mr. Robin Mann, who is Director on Digital Healthcare in a BCG company, representing Australia, which is one of the leading countries in implementation of new technologies in healthcare. Mr. Mann, could you please tell about your experience of implementation of digital support of doctor operation, about what kind of obstacles you met when facing clinical decision-making support system implementation, and how you solved this problem?
Thank you very much. So I'm hoping everyone can hear me. It's a little bit, the acoustics are
A little bit closer microphone, please.
a little bit closer. How is this? It's good. I thought I would address your question, but also start a little bit with a bit of a journey. So I was a doctor in the UK about 20 years ago, and at the time there was an explosion of evidence in healthcare, and everyone was needing to follow the best possible evidence and keep up to date with journals and learn how to appraise journals and identify if a piece of research was good quality or not so good quality, and make decisions about their patients. And it was very difficult to keep up then. And since then, the explosion of evidence base in healthcare has been enormous. And even in one specialty, you don't have time to read all of the articles that are relevant, let alone appraise those research to find out if what's happening. So the start of clinical decision support, in my experience, was in developing guidelines that were evidence-based. And that was trying to standardize care and to reduce variations in outcomes for patients. But we still have variations in outcomes for patients today, and we still struggle to keep up to date. So my role in digital has been, throughout my career, has been trying to help doctors to do the best they can for their patients and keep up to date with the latest information so that they can make the best decisions for them. And I saw electronic tools as being part of that story. And with an electronic health record or an electronic medical record, as we call them in Australia, it's possible to produce protocols in the system that guide the decisions that you make. And they use alerting, and they force people to go a certain way. And the problem there is that clinicians are told to do things that they already know is happening. They've made choices for their patients, which maybe the patients don't follow that particular protocol in that circumstance. And also the alerting is very frequent, and it's frustrating, and Marty mentioned that, some of that experience. So the critical thing with electronic health records is to make sure that you actually engage the clinicians very closely in developing the protocols, but also think about their use in practice so that you don't get alerts when you don't need those alerts. Today, things are moving on a little bit, and that makes life very interesting. So beyond just having an EMR system or electronic health record system, if you can get data out of that system, and you can use advanced analytics techniques now to actually run algorithms through that data and to personalize the advice for a particular patient. And in the future, we may be using genomic data to do this type of thing, but today it's more around processes and identifying risks for individuals. And not intervening when things are going okay, but intervening when things look like they're going off track for a particular person. And I thought I would give you an example of doing that from my last role, where I was the national CIO for a private hospital group in Australia. We decided that we had many different systems in our environment. We had aged care systems, we had community health systems, we had hospital systems. And some of those systems they weren't talking to each other very well, so the data wasn't flowing. So we built a data lake, which is like an enterprise-wide data platform that we were able to bring all that data into. And then we could use that data to run algorithms, and we were looking for complications of care. We were looking for patients who were at risk of developing renal failure, or they were developing sepsis, or they were slow to progress and recover from a particular operation. So we decided, we built this, and we had these algorithms running, and we were able to detect patients that were going into renal failure, and then we could tell we could also identify by looking at the record whether that patient was already being treated for this or not. So we weren't showing, telling the doctors about something that they already knew about, and we were then pushing that information to the doctors. So that sounds very exciting, but the challenge was that the doctors that we had as a private hospital system didn't spend all their time in our hospitals. They spent quite a lot of time in other hospitals. Maybe they were at home, and the care of the patient on a daily basis was with the nurses. So we had to find a way of getting this information to them in a way that was helpful. So we built a mobile phone app, and we built that with Apple. We had friends in Apple who helped us to design it, and we then pushed the notifications to them in the app, and then we found the doctors needed to know, well, is this advice correct? So we then had a feed through which would allow the doctors to look at the evidence for that alert, and even to read the patient's record. And then to make it even more useful for them, we were able to tailor, not just for the patient, but we were able to tailor the view of the information to the specific clinician and the point of care that the patient was in their journey. So if you are an orthopedic surgeon and you have a patient that is preoperatively pre-op, then we could show them the x-rays, and if they were post-op, the x-rays were less significant, and we would show them how far they were through the recovery phase of their care. So we built a system that was designed around specific clinicians and their needs for particular patients along their journey, and that seems to overcome some of the challenges that we had with implementing clinical decision support, because the tool starts to act as an assistant for the doctor rather than instructions being given to the doctor from some management team. We have a basic BCG client in the UK who did a similar thing, looking at opportunities and risks for patients who were at risk in different situations, and the evidence from that is that they reduced the readmission rate to hospitals by 40%, and also they reduced the risk of sepsis by 50%. So these things are coming on very nicely. So in summary, I think today's technology is the right time for clinical decision support to really start to help doctors to do the best things for their patients, and particularly to avoid patients falling through the cracks in the healthcare system when they may get missed, and therefore they get sicker and the outcomes are less good.
Спасибо. Спасибо большое.
Thank you very much, Mr. Mann. And now let's move a little bit further and go to Asia and talk about the example of South Korea. I would say that this is a unique country, and we have been keeping a very close eye on this country starting from 80s. And we should say that the country made a real step forward in terms of their technological development. It was a real breakthrough, and so they developed their technologies as related specifically to healthcare system. And I have a question for Mr. Lee Ho-yeon, which is as follows. I would like to ask you, what functions related to these systems to support decision-making process were taken at the Seoul Medical University and Bundan, how staff was motivated during implementation, and did it anyhow change the mentality of your staff or, I don't know, any medical specialist when it came to implementation of new technologies?
Пожалуйста, ближе микрофон.
Yeah. In our hospital,
Microphone is closer.
we are using several kinds of clinical decision supporting system. Some of them are developed by our clinicians, especially our nephrology method. So actually, as you know, the surgeon does not well known about the Renner tests, and they interpret it or sometimes just skip the interpreting some abnormal Renner function test result. And we made it some kind of an algorithm, so several kinds of diagnosis and a Renner function test has and medication has a problem is automatically make a consult to the nephrologist. So in that cases, our ARF acute renal failure cases has been decreased. And other things from the outside, what we're using is kind of a Medispan, is a kind of a giving a prescription helpful for the physicians. So as you know, so our hospital is a tertiary hospital, so many patients has very complicated this. So the doctors only knows their field, like endocrinologist only knows their drugs, but cardiologist knows their drugs. But sometimes those kind of a medication has an interaction between what they prescribe. So those kind of things are helping that not to overdose or some of the drug interaction to skip it. But the problem is that the many doctors are feel fatigue about too much pop-up. So what we made it is when when they have a similar pop-ups are coming up when they follow up the same patients. So we made it that if the patient's pop-up is already and clinically you think it's not important, you can make a memo at their click and then it doesn't pop up again. Those kind of things are going on, and Other things are doing by governments. Our governments make a drug utilization review program. So some patients are not visiting only our hospital. They are visiting other hospitals in their hometown. So the medications informations are gathering into the government and compare with what they prescribe in the hometown and in also our hospital. So if there is overdose or something is duplicated, the system let us know that not to overdose for the patients. And recently, there are many new drugs are coming up, and some drugs are very complicated. Like there is some kind of option for the medication, like renal function should be safer, and if the patient has some options, the medication should not be prescribed. Those kind of algorithms working on to reduce the error, human error by the clinicians. And the final is our government DUR system has engaged to the airport. So some patients have been visit the outbreak area and became to hospital with fever, and the doctor could be know his or her record about the foreign countries, so we could prevent the outbreak inside the country. Okay, that's all.
Спасибо. Ну, а теперь давайте от Сеула.
Let's move from Seoul and travel 7,000 kilometers to Moscow, back to the northwest. I have a question for Yulia Urozhaeva. I do understand that Moscow is a little bit further from that. So can I ask our speakers questions, or can I do it a little bit later? No, we'll do it at the end. So Moscow is a little bit separate from the rest of the country. We have different economic opportunities in Moscow, and the size is different. And of course, we have a lot of different programs as to how we can implement technologies right now. We also focus a lot on artificial intelligence. We try to support this system, the decision-making system. So what is now happening in Moscow in terms of artificial intelligence? Is it being intensely used, especially when it comes to, for example, decision-making process, since we talk about this? Do you need any support? No, we don't. Okay, just let me know if you do. You see, our technologies are really front-end, really breakthrough technologies. They're trying to help us. Yes, you know, this is a question for Yandex. So this robot is trying to be helpful, even though that it wasn't asked to be helpful or to assist us. So my name is Yulia Urozhaeva, and starting from June last year, following a decree by Mr. Sobyanin, together with the Ministry of Health and Chief Specialist of the city of Moscow, we started work in order to develop this system to assist our doctors during decision-making process. Well, like colleagues say, yes, we also studied different experience and approaches from Asia to America, and we understand that when we talk about this kind of system, we sometimes mean different things. Yes, sometimes I see that, yes, we talk about artificial intelligence, but it's not always artificial intelligence in the true sense in these words. I'm very thankful to my colleagues from Moscow. First and foremost, we decided to focus on medical specialists and clinicians, and we created a special working group who try to explain us where they need assistance and what kind of assistance they actually expect from us. So could you please bring the next slide to the screen? So we decided that the system will be established along the whole treatment line of the patient, starting from the primary visit, then the repeated visit, then well, here we have different other scenarios. For example, further control, hospitalization, etc. So we decided that we doctors need particular assistance, especially at these difficult nodes where we have, of course, quite a big number of standard cases, but also there are certain cases where doctors needed to be somehow supported. So how do we perceive the system? This is a set of digital instruments, quite a few instruments, and they are there to assist doctors in quite delicate or tricky points. I would like to say that this is not a unique, complicated artificial intelligence taking decisions instead of doctors. So it's not a system that will be taking decisions for you, sort out every issue. No, we decided to segregate it into different instruments that could be used at every single step at different levels. So if we talk about primary visits, well, we started to analyze what kind of information a system can gather. So we developed special questionnaires for our patients, and they will be available at our portal very soon. So patients, before even visiting a doctor, can fill in special information regarding their past medical history. Apart from that, in special medical history, it will be possible to fill in your diary, introduce your information regarding your pulse, your blood pressure, etc. And then the next step is the visit itself or appointment with the doctor. There we work with the complaints put forward by the patients, and there we decide that based on the claims outlined by the patient, it helps the doctor to understand what kind of body parts deserve particular attention of the doctor, particularly during medical checkup or in the so-called inspection. So it could be quite a typical or standard case, but also sometimes we have more complicated cases, and doctors might forget that they also should pay attention to some other body parts as well during a particular situation. It is now being tested, and we hope that these experiments will turn out to be a success. We can use artificial intelligence-based instruments in order to give doctors a hint regarding the diagnosis that should be expressed. So today during the preliminary session, Vadim Reshetnikov said that they also think a lot about such instruments, and we know that it has already been implemented in many regions, and if we use information that we already have available in Moscow, for example, and in other cities, for example, Ufa and many others, and put it all together, we could have an even more rich database. So speaking about the next instruments, so once we have a certain diagnosis, we have certain checkup packages, that's how we call them, which includes different information regarding the patient, and also it gives the doctor recommendations regarding next steps. So previously the doctor was supposed to make a choice and to send the patient further on. I mean, and it took a lot of time, but now it is done in a more automated way. So the doctor can come up with the right route for the medical route for the patient later on. And again, I would like to say that it helps to improve the quality of the diagnosis, the accuracy of diagnosis. So we even at the 8th stage get quite very interesting packages. We already have developed 33 packages with different situations that could be used already by some doctors in some field of expertise. We have already launched some pilot projects in December last year, and we already saw that it can help us in the future to optimize time needed for a primary visit and the first steps that are taken after the first primary visit. We also saw that it could help doctors to even come to very interesting conclusions for themselves. Because we were receiving some feedback, and it give us an idea as to how we should develop it further on. I'm not going to dig deeper into details and go through all the steps, but just to give you an idea, I would like to say that here we talk about certain instruments and that can be used as a certain guideline for doctors when it comes to prescription. Right now we have over 30,000 different drugs, or I don't know, maybe even more of them. I mean, the basic ones. Before that, we have only 10 of them. I mean, I don't know, 30 years ago. But now we have a lot of different drugs, and we already have a special package that can be used by doctors, for example, for cardiovascular diseases and for some other diseases. And we also have some information about drug compatibility. We have special graphs and special compatibility algorithm that are also an integral part of this instrument. We have some instruments for the doctor to decide on a planned hospitalization or also non-planned hospitalization. I would like to summarize and say that yes, I could talk a lot about that and about all the instruments that we are now developing. Right now it is just a pilot project, but I do really hope that it will be of great assistance and help for the doctor. But it will only be efficient. It can only be efficient if doctors are also able to accept it and to understand the importance of it for the medical sphere. First of all, it allows us to improve the quality of protocols, also the speed of decision-making process. And I would like to say that the best systems are always based on very transparent and accurate clinical information, whether talk about clinical information or recommendation. We, for example, should say that our system based on 45 high-quality protocols that was developed with participation of very professional specialists. We are trying to develop it even further in close cooperation with such experts in their domain. Thank you. Thank you, Julie. Later on, I will definitely have questions for you as to how it is implemented and how it is paid for and how it is funded. But now let's move a little bit higher to the federal level. And my next question goes to Vitaly Emelianovsky, who is responsible for the development of clinical recommendations and guidelines at the federal level. Vitaly, I have a question for you. Could you please tell me what are the perspective regarding the implementation of such systems at the level of the country in general, at the global level? And do you have any kind of approach or plan, step-by-step plan as to how it should be implemented so that it could be really accomplished at the federal level? Yuri, thank you very much for the question. So since our center is involved in developing clinical recommendation, this is quite a simple question. And very often we are asked how we actually supposed to work with such clinical recommendations. I have only 8 minutes. I will try to be as brief as possible, but still cover this issue in details. Right now we have a lot of young people here, but 25 years ago, when I was just a student, there was a popular book called Cardiology in Algorithm. And there was a very detailed information about all the cardio diseases in a very structured way. So this book was very popular. It was a real guideline for us, and it was very important to have this kind of book. And now when we talk about implementation of the system to boost decision-making process, I would say that there are two major components to that. On one hand, we want to improve our information system and to use it to help us. Of course, it could be used as an assistant to help medical specialists, but there is also another important component. We need to think about composition, about the content of algorithm. Maybe our foreign colleagues will also be able to answer this question later, when they developed this decision-making system and this assistance system, they understand that we have concrete individual patients with a specific age, with different diseases and comorbid decisions, and we need to find answers to all the possible cases in a structured way in order to have a real instrument. I talked to our Spanish colleagues, and the first question I asked them was as follows. I said, I'm not interested in information system. I asked them, where do you take information? And I said, you know, we try to engage doctors of leading clinics and hospitals, and they developed a certain decision-making algorithm, and later on our system will be based on those algorithms. Either they get a certain remuneration for them, or sometimes they do it out of love for medicine. But how do they do that? I ask them. Based on their personal opinion, because you know your personal opinion is just your personal opinion, but we need to have certain proof, like we say, medicine of proof, and this kind of approach is to be at the basis of this system. It's a very important component that are used to develop algorithm for our doctor. As for clinical recommendations, this is the basis that should be used by our developers, but there we don't have answers to all the possible questions and challenges that the system might impose.
That is why here we should have a very clear group operating, a group with high demands, and actually what is being done by Moscow right now. And Yulia Urozhaeva, who is promoting that, well, I would like to pay tribute to that. And another thing I would like to specify, rigidity or being open to different variations. If we see who needs this, we can say that this support system is important for everyone, but truly I'm firmly convinced that a specific doctor who is curing a specific patient doesn't want that. He wants freedom. That is why implementation of any system of quality control is not always positively taken by doctors. Who wants that more? An administrator? Why? Because administrator wants to standardize the process of medical assistance. And if we remember, or if we try to think where, first of all, algorithms should be implemented in urgent situations, emergency, a heart attack, 100%, it should be standardized, and only after that informatized. That is why the support system should be started where it is really urgent, where people have no time to think. Do this way and you'll get the result based on the data we have. Another thing I would like to specify, that implementation of digitalization is not possible only at a working position. Well, at home I will still watch analog TV and use the disk telephone. This is a new way of thinking which should come to all of your life. And maybe if we impose this system of clinical decision-making support system, we will develop doctors, and the needs of a human as a personality will also be growing. And I would like to specify another thing. The period of digitalization for our medical institutions lasts for 10 years approximately. And normally when you come to the chief doctor, you ask, do you have an information system? Yes, of course. When you open it, what can you get from that? How many patients they got, what kind of complaints they have, and claims in Word or PDF. So what we cannot analyze in any way. And today we create the clinical decision-making support system. We must understand that destructuring of or maximum structurizing of this data, well, tomorrow this data must be provided for analysis, and there should be people who understand how to analyze this colossal amount of data which will be accumulated by the system. What for? Because feedback and arrangement of the algorithms that we do not know yet how they should be created. Well, this huge massive of data will make it possible for us to arrange different kind of correlations and understand how a doctor should act in this particular way. And the last thing I would like to mention, probably, well, of course, today, Ministry of Healthcare arranges a system, and I personally actively support the system, and this is and we actively promote this system. Clinical recommendations are ideology of treatment. Clinical recommendations do not answer how to treat this specific patient. This is ideology. Then, a system, the system of clinical decision-making support system, or protocols of treatment, or algorithms of treatment, or packages are something that should be based on clinical recommendations, something that should be directly connected to the existing reference books regarding medical drugs, services, medical items, because each of them would have its cost. And when a clever, intelligent administrator will arrange this clinical decision-making support system, he will calculate better, and he will understand how much money they need. That is why, speaking about this decision-making support system, there is an important system of arrangement and quality management system, without which tomorrow will not be able to increase the status of healthcare institutions. But all this should not be of chaotic character. It should be arranged very systematically, very thoroughly, and built into the system of healthcare, which is developed by every specific country or subject of federation. Thank you. Thank you very much. I suggest that in the word of our next speaker to develop the idea that Mr. Amelnovsky started. Well, this clinical decision-making support system should not be a thing inside itself. If it's just an assistant to a doctor without accumulating of statistic expert massive of knowledge, then based on this system we will not create any kind of managerial decision support system. And altogether that should be integrated into totally new and other complexes and programs. So I would like to speculate about it. Alexander Gusiev, being member of Expert Council of Ministry of Healthcare on issues of using of information technologies, and a specialist with a large experience of implementation of specific medical and digital systems into medical institutions and regions. Well, thank you, dear. Good afternoon, dear colleagues. Please, next slide. I would like to say that clinical decision support system are developed and they're present at the market for 50 years already. And I agree with Julia that this is kind of a vast notion, and people are trying to bring everything to it under its umbrella. And first of all, I would like to quote one of the definitions of CDSS, which was given by a regular doctor from Canada who was working with this. And he suggested the following definition, that CDSS is software products which connect knowledge with data of specific patients, and through that helps to somehow increase efficiency of doctors' work. This is a very vast definition that can give answers to many aspects that we're discussing today. Why we are speaking so much about CDSS? There are lots of key trends which are growing annually in huge tempos. The first trend consists in the fact that the amount of generated medical knowledge is qualitative knowledge, and huge medical research is growing like avalanche. And today there is no doctor who can remember all this knowledge personally. And another trend is that the amount of data about every specific patient is growing exponentially. A specific example, I was recently told by clinical doctors, what do you think, how much a small probe of venous blood can provide a data related to a patient in bytes? How much information can be generated? Like 50 megabytes, gigabytes, because 750 megabytes sequenced genome and cells if some pathological processes in high definition, and some bytes immediately related to lipid spectrum and so on and so forth. So just imagine if just one probe of venous blood gives 1 gigabyte, then how much data can be gathered about one patient for only one visit to a doctor. And this creates the following conclusion. Today, there is not a single doctor who would, under any condition, analyze all the amount of medical information that can be given through technologies, equipment, and so on and so forth. And this creates huge problem. The problem is like this, half joking, half severe. Well, today, we all know that when we do not know the law, it doesn't mean that we are free from obligations and liabilities. The trends in legal practices and in expertise, which was mentioned by Vitaly, consist in the fact that this phrase can be restructured, that a lack of knowledge or disability to digest medical knowledge about a patient will not free the doctor from responsibility. And this is a severe tendency which creates demand for CDSS. The market is quite large. For the last years, we see the acceleration of this market development, and as to the world measures, it's quite small. In the nearest couple of years, it will grow up to $2 billion, but it is one of the key markets of digital healthcare. CDSS have lots of problems at every stage of development, and at this stage, the recent year or two, as specialists, we see two main things which are specified by serious research. The clinical decision system support is a class of products. Doctors do not use technologies. They do not use clusters. They use specific software developed by specific programmer. And the problem consists in the fact that if CDSS has lots of proof bases and lots of research is confirming clinical efficiency, influencing over outcome, this database is there. And if we come to program products, far and away not every vendor will prove their capability. Not every producer will make like prospect clinical researches and influence over their products to the results, efficiency, and so on and so forth. And once again, we remember the definition given by a Canadian doctor that the main target of CDSS is effect. The second problem consists in the fact that the better CDSS are developing, the more negative effect they provide over doctors, because there are lots of different elaborations. A doctor is with a patient at examination, and he will see lots of mistakes and notices, and sometimes doctors are burnt out at working with CDSS because there are constant notices and recommendations and alarms, and the doctor starts getting irritated, starts getting tired, and we have a very bad situation. So the better the product is developed, the more you want to get rid of that. And the last slide, well, technologically, from the point of view of production of these products, I would like to specify three trends which are clearly seen in a recent time. We see them. The first trend consists in the fact that CDSS is very expensive and very long from the point of view of establishment, because we truly need a database. We need lots of experts to validate the knowledge and the data. And alternative way of development consists in the point that we can use big data, machine learning in order to drag out this knowledge automatically and not put in manually. The second trend consists in the fact that CDSS can be based on researches, in retrospective researches of big data for searching of new knowledge and new predictors. Specific examples I can provide if you need. And the last trend, which is very bright, it consists in the fact that many years ago, like 5 or 10 years ago, lots of CDSS were just applied products. A doctor should enter CDSS, ask something, and he would have an advice. And now CDSS are popular as services. When a doctor worked in digital medical history and not in number of different products, and digital medical history would address to CDSS as services, get the result of their work, and either puts it down into the medical history or shows to the doctor to the screen, softly and carefully, helping not to make a mistake. Thank you. Thank you. Thank you for this information, but I would like to expand your assessment of this data from one probe. Just considering that using biomaterials you can do total genome sequencing, I would like to raise this figure, and actually the size of a file, totally sequenced genome, will make 200 gigabytes for today. And well, it's quite clear that the size is huge, and if we press it down for storage, not to store it as raw data, but store only results. I've read a couple of works that we managed to make it 750 megabytes, and for analysis, or the CDSS analyzes not raw data, but it analyzes violations or some genomic mutations and so on and so forth. But truly, we have lots of data, and it's very hard to remember it for specific doctors. It's actually impossible, and we're speaking about inevitability of automatization processes as a result of development of products based on artificial intelligence, but we'll discuss a little bit later. And now I would like to give the floor to Mr. Hans Alois Wischmann, and I would like to ask him to speak about his vision about how it is possible to use the newest tools of CDSS, how you view this with the experience of Royal Philips Company.
Thank you very much for the question. Appreciate the invitation to share that with you. Yes, I'll speak closely to the microphone. Next slide, please. So I wanted to structure the few things that I wanted to say along the following areas. We totally agree with what was said earlier, that you need to show benefit on patient outcomes, you need to show cost containment, you need to show benefit to the overloaded clinicians. So I wanted to show you one example where the combination of clinical knowledge and AI technologies has done exactly that. There is also the question, why would clinicians be motivated to accept some of these tools into their daily life? And we typically hear that it is workflow improvements, less hassle, but I wanted to show the example to you that shows that there is actually much more to it. Helping them do the job that they are passionate about is probably the best we can do. There is a question in the room always about trustworthiness of what we are doing. How can we trace it back to the data? And it's not just garbage in, garbage out. It is actually needing to document that there is a reliable part to it. We struggle in our experience both with overtrust as well as with undertrust, and I wanted to give one example from literature that shows exactly where we should sort of situate ourselves there. Next slide, please. So the example that I wanted to show you here is one where we started with guideline-based care, where we looked at patients that are typically in step-down after intensive care units, and where we're looking at what an early warning score automation on the general ward can help do. So this starts with guideline-based implementation of the known parameters for predicting a risk that something will happen to the patient, but it adds data-based elements to it. It adds correlations that are not visible in the guidelines to try to individualize it better to each individual patient. So the task that we need to do here is actually, together with clinical partners, curate the data set that are taken from these step-down patients, create a predictive model, and then go through the tedious task of a prospective validation of such a model to see whether it is A, accepted, and B, does have a benefit. And then the benefit that we actually saw in the study that I mentioned here was that by having this additional information, we were not increasing the workload, but quite on the contrary, we were reducing the number of cardiac arrests that happened in the general ward by 5-6. So 86% reduction of the surprising cardiac events that needed a scrambled rapid response team to intervene. What was more important was that it did not substantially increase the number of people who were pushed back to intensive care, but that the people who were pushed back had a higher survival rate. So if you look at this from this perspective, you've got cost benefits because you can have the patients in the general ward, but at the same time bring them back for a better care to the intensive care unit on time. You have less stress for the individual doctor, and it's actually helping them to do what they're extremely passionate about with a lower workload and a better patient outcome. So except for patient experience, which is very difficult to measure here, I think you tick many of the things, and to the things that my previous speakers said, it is actually the combination of clinical knowledge with the pattern detection in the data. If you go only about pattern detection, there are very bad examples that you can fall into. If you look only at 6 months survival of patients who present at an emergency department with respiratory problems, and you look at whether they had previously asthma or not, there were studies already in the 90s that the patients with asthma survive much more than the patients without asthma. But that does not mean that you should be sending these home. It is related to the fact that the workflow actually moves these patients to the intensive care unit immediately. So you cannot just let the data drive your insights. The data creates correlations. You can create hypotheses on that with clinical partners, and you need to carefully validate those hypotheses. With respect to the motivation, the doctors are extremely motivated to use these sort of tools because it alleviates their workload and improves care for the patient. Trustworthiness. Here we needed to invest into curating the data so that also the AI component on top of it was reliable, because nothing is worse than inundating the doctors with useless triggers, reminders, or other things. So it needs to work very, very well, which means it cost us a few years of curating the data that we learned from. I'd like to show you an example, and that's the next and last slide that I wanted to go into. And this is not our work, but it is work that was recently published in Nature. It's an article that attracted a lot of media attention. The first line of the summary of the authors actually says, in this study, we present an AI system that outperforms radiologists. And that, of course, attracted a huge amount of attention. What I would like to invite all of us is to do, okay, this is a difficult technical slide, I'll walk you through it in a moment, but you actually need to go to the scientific validation and publication to understand what you can trust and what you cannot trust. Because if you look at the slide, and so this is a typical AI curve to look at different operating points for sensitivity and specificity in a screening environment, they compared it, and they very clearly said that this is not claimed to be ready for clinical use, and we totally agree. What you see is the curve is above that green dot, which shows the performance of a single radiologist doing a mammography reading in a well-trained environment in the United Kingdom. So the curve clearly outperforms that first single doctor. The first concern you have is looking at the blue dot. The blue dot is the second doctor, which in the UK always reads as an overread a mammogram because of the high risk associated with missing something. And you already see that the curve from the AI tool is slightly below that second doctor, because the second doctor knows what the first doctor had said in addition, and so actually outperforms. The system is, however, in most European countries, including the UK, set up to break a discordance between the two doctors, and that's what the red dot is showing. The red dot is showing the consensus result of the two doctors that are always there. So the lesson is, if you follow from the green dot, the dotted arrow, you can improve sensitivity and specificity than a single doctor reading. But if you follow the green arrow that I added into this thing, you see that actually the consensus standard of care that is currently in place is so much better than the AI tool as the AI tool is than a single doctor. And if you were to naively replace the consensus part which is there by the current implementation of this particular AI tool, you, at the same sensitivity level, you would actually double the false positives. So what I'm trying to say is, we should not undertrust. If an AI tool like this, coming from a very reputable group of scientists, is better than a single doctor, the time has come to take it seriously, and the time has come to find its right place. The authors actually go on to show that the second reader may potentially be replaced by the system, and if the second reader AI system agrees with the first reader, you can reduce by 40% the workload for the second reader without giving in on sensitivity or specificity. And so those things of combining good clinical knowledge, patterns that are learned from statistical data, curating it, validating it, and then putting it in context allows you to develop the healthcare system further. Naively jumping on it just because the New York Times or a TV channel touted it as better than radiologists is jumping to the wrong conclusion, as is over-trust. The right trust here is to take it seriously, to try to put it in the context, to take the good science and say, okay, the next step may be to actually validate it as a second reader replacement when it concurs with the first reader. We try to go down exactly that path and try to say, what can we, in partnerships locally, take models that we are developing, put them into the right context, evaluate them on the subpopulation of interest, not replace the doctors, but augment them with meaningful additional insights. That's, I think, the best way that we can hope, and that's our experience. You can find a way in between the overtrust and the undertrust, but you need to do it extremely carefully, and it's a partnership between the technicians, the clinicians, and the people who are paying for the service. And unfortunately, it means we all need to read the scientific publication in detail, because the first line of the summary just doesn't cut it. Thank you.
Спасибо. Спасибо большое, господин Виш.
Thank you very much. Well, you did a great job. I absolutely agree with you. Don't you trust me? I could also be trustworthy. So our robot also like that. Well, being the moderator of the session, I would like to address the first question to you. So apparently that is just a matter of time, as to where these expert systems based on artificial intelligence become an integral part of our healthcare system. But the question that's particularly relevant for today is who is supposed to pay for that? You here representing your company, one of the developers for this diagnostics systems. Do you think that these CDSS systems based on artificial intelligence that could help us, for example, with diagnosis, will they become a part of the diagnosis equipment and will be put into the price for this equipment, or will be it paid separately as a separate service? I'm asking you because today in Russia we are asking ourselves this question, and we have been doing that for quite a while. Because we understand that we need to have a clear vision of the distribution markets, specifically for the system based on artificial intelligence.
Thank you for the question, but unfortunately there is not a single answer that covers it. There are different areas.
A little bit closer to microphone, please. Yeah.
Thank you for the question, but unfortunately there's not a single answer that I could make for you. It depends on the context. So in some cases you will have artificial intelligence which just increases a reconstruction, for example, of an MRI or a CT machine. There I would expect it to become part of the state-of-the-art in the machine. There are other areas where you're improving workflow, and there it's a question of whether the benefits can rightfully be shared between the ones who create it and the ones who benefit from it. There are third elements where you're actually increasing the quality of care and reducing unnecessary cost later down in the line, and in those cases you would need to see that, how something is reimbursable there as a part of an improved standard of care. So it depends. Some things will be in the machine, some things will be improving the throughput, improving the ability to scale, and some things will create a totally new value. Each one of those needs a separate discussion, and I cannot offer or volunteer a single simple answer for that cuts across all three.
Thank you. Спасибо.
Thank you very much. I have a similar question for Yulia Urozhaeva. I do understand that right now we are trying to implement, you are trying to implement pilot projects, CDSS, and also some medical establishments in Moscow. So what about payment issue in your work? Is it supposed to be covered by a special foundation or some budgetary spending? What kind of answer do you have? So you have the systems, but how will they be paid for? Apparently, approaches to artificial intelligence-based systems, they are quite unique for now, and of course they are at the same time could be or could not be an integral part of information systems that already exist at medical establishment. I would say and absolutely agree with the previous colleague speaker that there is no single answer to that. Today with our colleagues from Korea and many other countries, we talked about the following thing. We need to think about the results that you want to achieve, results for the patients, for the doctor, and also the expenses that you will have to carry. If we see some really tangible results, and the fact if we manage to cut down on the time that is needed for diagnosis, then we will be able to understand that this is the product that we need and approach the rights. And also, when we have a clear vision of the whole picture system, then we'll be able to understand how it will be paid for and where we can actually optimize cost. If we compare artificial intelligence systems based on databases and use of this data, they started to implement it in production, for example, 5 years ago. For example, different factories and plants, there they work with some spare parts, with conveyors, so these are not living organism, just some parts, and they use it for different processes involved. But at the same time, even some production companies and factories, they still cannot make it to the next level for a long time. I mean, from the pilot project to a real implementation during production. Yes, on one hand, medical sphere is more complicated, but even in production sphere and different factories, it was really complemented to make a real step forward. But I should say that it takes time. It doesn't matter what kind of field of expertise we talk about. It's not a trivial question. We have a lot of challenges. We need to probably have an idea as to what kind of golden standards we should use here. And apart from payment issue, there are many other issues as well. I would say that one of our main challenges is not to understand who's and how supposed to pay for that, but what the system actually is going to look like, and is it going to be really efficient for medical specialists? And can we do something to make it really efficient for us? We need to keep track of our achievements, and we want it to become a real assistant for medical specialists rather than trying to impose it on them. Vitaly Vladimirovich, I know that you also had some discussions, some remarks, and also questions for our colleagues. Well, actually, I wanted to come back to your question because your question is really interesting. Today we talk about CDSS, and we say that this is one of our innovative technologies. They have their own database of proof and basis in general, and our colleagues today show that we already have some economic vision as to how we will have to pay for implementation of such technologies and where we could actually save up a little bit on that. I don't want to talk only about Moscow because Moscow is a separate issue. I want to say in general that any new technologies, whether they will help us to save some money or to, I don't know, to optimize cost, well, inevitably it takes certain funds and money to implement it at the very beginning. And I would say that even a technology that long-term in the future will be helping us, and also in terms of optimizing cost, it requires certain investment at initial stages. If we want to develop a system, well, except probably for some big private hospitals or clinics, hospitals, they can afford to have such systems in place, but small hospitals, they cannot afford that. And another question, if we already have such a system, and if it is, for example, acquired by a hospital, or a hospital gets it for free from the state, then we need to understand if this system and this technology has turned out to be helpful, then of course they will supposed to generate some benefits, and of course the owner of such technologies should make sure that this technology will be really working in the true sense of this word. So we need these owners to understand the benefit and advantages of such technologies, and we must enable them to implement it in the right way. Well, of course, I would like to say the following thing. We need to have different sources to invest those technologies. We need to have some budgetary span, and I mean something that will be subsidized by the state, but also we want to some private hospitals to be involved. We also had a question for our colleagues. So I just asked them how they develop their system and what serves as the basis of their algorithm that they used in their clinical decision system, support system. And another question that I would like to address to them and to Julia. Today we are developing a CDSS and the doctor, whereas the doctor is supposed to act in a special way based on this system. But we should say that still the doctor is the final person or unit to take the decision. And if the doctor wants to avoid the machine, the system, if the doctor has his or her personal opinion, then they must have a certain provisions to substantiate that documentarily, you understand, because if it comes to some legal suits or some judicial problems, then there should be some substantiations based on what the doctor decided to follow her own decision rather than to follow the advice given by this CDSS. Mr. Mann, I would like you to answer the question by Vitaly.
Thank you. So you asked how we developed the system. I think we used a very standard way of doing that. We had, in terms of the algorithms, we have the data scientist that will work on the algorithms. You can use, sometimes you need to work out what elements are driving what. You may not know that the outcome you're looking for, what's causing, what the cause and effect is of getting that outcome, what you have to change. So you can use machine learning in the code to look at all the different correlations and work out what the greatest drivers are. That's one technique that's been used. In terms of the doctor having the final say, I think absolutely there is no current system, and we've just heard of one of the most advanced, which can tell you, can outperform a doctor all the time. One thing I would say, though, about the radiologist example is that just because the system at the moment is not at a radiologist, it doesn't mean that you can't use that system in practice, because there are examples in the US at the moment where they've got a diagnostic imaging which actually helps to prioritize those imaging that patient for reporting by radiologists. So you don't change the way the diagnosis is done, but you push those high-risk patients up to the top of the queue, and that's reduced the time to diagnosis for patients with cancer by about 90%, and that obviously then has a net impact on the outcome. So I think there's ways that you can use technology today, even if they're not necessarily quite at that sort of autonomous stage yet.
Thank you. Юлия, поучаствуйте в ответе на вопрос Виталия Владимировича.
Could you please help Julia to help? Data science is the person who works with data, big amounts of data. But the question, when you form different algorithms or options for diagnosis or for treatment for an individual specific patient, where do you take information? So we said that CDSS is a system that frees the doctor from getting to know a lot of data information. But we know that today we have a lot of Cochrane, Jane approaches, etc., that based on a set of data or proven data can become a part of clinical recommendation that they can use. So at the level of CDSS, how do you make this relations between clinical instructions with particular behavioral patterns of the doctor that is also shaped by CDSS? Vitaly, it's a very important questions, philosophical one, an ethic one. Right now, we had quite a principal solution, and we say that a system should not impose any limitations on the doctor. It can accompany the doctor, but the doctor is always free to take the final decision. For example, in Germany, if I mean, we said such a an expression: if you try to analyze your symptoms with the help of Google or Yandex, then you should get further treatment there. No, I mean, it's not the case. We should see that the doctor still is fully responsible for the decision made. It's just like you if you try to perform a diagnosis on your own with the help of internet sources. Yes, so we use these beautiful words, digitalization, but there are a lot of details, a lot of work behind this beautiful work. A lot of work has been done in order to structure all the data that stands for this word digitalization. You have to understand that we developed a number of guidelines already, and we're just trying to also digitize it somehow and to just make it more palatable, to make it more structures for it to be used by medical specialists. I just want you to understand that big data help us a lot, but if you really want to use this data, it needs to be structured. So do you know the so-called husky phenomena? Sometimes it is difficult to make a difference between a wolf and a husky, but all of a sudden we can use one mathematical algorithm that with a 98% accuracy can give you an answer whether it's a husky or a wolf that looks like a husky. And when they look deeper inside, it turned out that the system did not look into the dog or the wolf itself, but environment around, because the system analyzed other parameters as well. For example, if the animals were standing on the ground with the snow around, so they made the conclusion that that was a wolf, etc. I mean, many other parameters, and it was just simply analyzing the nature around the animal instead of looking at the eyes of the animal or fur, etc. So we do really hope that in the future systems will be developing, they will be assisting us, and they will be becoming more and more accurate. But why we first asked about Yandex, it's true that we are actually quite afraid of side effects of this system, so to speak. Yes, for example, we get a diagnosis, certain assistance for the medical specialist, but doctors, they must still remember that they are the one responsible for final decision making. Do you remember when we started to use navigators or GPS in our cars, we lost any sense of direction, so we were just guided by those navigators. How we can avoid this navigator effect? Because when you just look at your navigator in the car, I mean, you completely lost if you don't have any in front of you. Well, unfortunately, we are running out of time, and we will continue our discussion on the margins of our plenary session. And I would like to proceed to another round of voting. Could you please bring our question to the screen? So the second part of interactive voting, what is the most valuable thing for you when it comes to CDSS? Time saving, diagnosis accuracy, the quality of patient routine, medical routine, or the fact that it can accomplish a big number of routine stuff, or see no value at all here?
Ну что ж, уже видно.
So we can already see that the leading answers are for time saving and precision of diagnosis, which we could have predicted that these answers will be leading ones. And you also see that there are answers I don't see any value in this. Well, it is also possible. So let's stop voting related to this. And next question. What's the most serious barrier you see for implementation of CDSS? Technological readiness of the system, capability to build into the current information system of hospitals the degree of staff preparation, legislation limitations, low efficiency due to high percent of mistakes, absence of solutions tested in real-time conditions, and fast outdating of data sources for CDSS. Well, the leaders are already visualized. This is technological readiness or technological unpreparedness of systems, legislation limitations, and liability for the decision making, and also staff being not ready. So technologies are not ready and staff is not ready, and regulatory limitations. Well, we stop voting, and the last question, select 3 tools of CDSS which you are ready to use starting from tomorrow. Processing and deciphering of analysis results and diagnostics, analysis and control of efficiency of treatment and possibility of complications, prevention of duplication of procedures and analysis, automatization of medical documents filling in. So, automatization of medical papers as one of the basic pains in today's medical routine is at the first position. Number 2 is analysis and control over efficiency of treatment and prediction of possible complications. So we stop voting. So, dear colleagues, summarizing today's event, I would like to once again specify the fact that digital healthcare is developing with the support of CDSS and equally with the digital medical histories and telemedical tools, and also developing systems in the area of artificial intelligence. Well, it's one of the main technological trends within the frames of digitalization of healthcare. And here, Russia, being a country which is considered traditionally behind as to medical technologies, can have a chance to get involved into world processes and at least not to stay behind, but maybe become among leaders. Whether we are going to have enough of political readiness, I don't know, but as to competences, I'm firmly convinced we have enough of those. Thanks to everyone for your attention. Let's applaud to our guests who joined today's session, and let's wish successful work at the forum to each other. Thank you. And thanks to moderator.